Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on the physicians and practitioners who are redefining medicine through their integrative, functional, and holistic approach to health and well-being. Our host for Redefining Medicine is Dr. Erica Schwartz. For more than 20 years, Dr. Erica has been at the forefront of advanced patient care, taking the best from conventional and integrative medicine and applying them to prevent disease. Dr. Erica is a distinguished A4M faculty member in disciplines ranging from hormone therapy, peptide therapy, and IV nutritional support.
Hey, welcome back to Redefining Medicine. We're still in Boston, and we're still talking about how to integrate medicine, healthcare, from the perspective of A4M and IPS, International Peptide Society, and how to bring things together. How to actually realize that we're talking about human beings, 360 degrees, and that everything's connected to each other, and everything starts at the very beginning, and it's a developmental issue. So to that end, we have Dr. Deb Simkin with us, who is a psychiatrist. Thank you so much for coming today.
Oh, thank you. It's the first time I'm at this meeting, so it's been fun.
Oh, great. That's great. Well, talk to me about the type of psychiatry you practice and what you think should be done.
Well, I'm co-chair of the American Academy of Child and Adolescent Psychiatry's Complementary and Integrative Medicine Committee. And I also teach at Emory. We teach all the residents about functional psychiatry. But I think it's the future of medicine, period. Whether you're doing psychiatry or you're an endocrinologist, you've got to look at the whole person. And I think what really has to change in teaching in medical schools is, rather than telling someone to specialize in one area, they still need to be able to know about the whole person, as you said. And I think that's what a little different about me, and I was just saying this earlier, that I think psychiatry, even if you stay in that specialty, is a little bit backwards. We should be doing child first and then adult, because you've got to have an understanding of why that adult in front of you got where they were, right? And so I put a lot more emphasis on neurodevelopment. And so, for instance, not just a matter of knowing neurobiologically what happens to the brain as you develop. If you've had insults on that brain while that particular area of your brain, so like the HPA axis, was developing, and now you have an increased stress response, then the person you're sitting in front of, you may have a better understanding about why they act the way they do. And it's not borderline necessarily, right? It may be something else. And from my perspective, I think that DSM is not something that's useful to me. It was necessary before we had all of the type of technology we developed in the 90s, not me personally, obviously, but you know, we have functional MRIs. And, you know, 200 years ago, you know, when you started surgery and you opened the gut for the first time, you saw what was going on. But you've had 200 years of information and research that's come out, and it's dribbled down to the normal population. So they get a right-sided pain, they go, oh, appendicitis. But what we've learned about neurology or psychiatry has only happened since the early 90s. And so the problem for me has been, one, the general public still sees any mental disorder as a stigma, a weakness, and not a medical disorder, because it hasn't had enough time to dribble down to the normal population so that they're familiar with it. But also, I think that my own colleagues, when they look at this, they're not really looking at, well, yes, we know more about what's going on in the brain, but what was going on in that brain in development that could have influenced how that brain works today, right? So my talk was supposed to be in psychoneuro and immunology, and at first I thought, oh, I've got 2 hours, and then I got into looking at what I needed to say, and I went, 2 hours won't be enough. But there's a lot of ways I could have talked about it. The way I chose to talk about it today was depression and PTSD and trauma. Because I think when you look at trauma, and ACEs, adverse childhood events, it is the reason we have chronic disease in this country. And it causes more deaths than anything else out there. And we have to ask ourselves why. You know, if you go to a pain clinic, and actually with some research on this, they looked at people who had ACEs or childhood trauma, especially under age 7, because that's when it has more of an effect. And most of those people, by the way, are not responsive to traditional psychotherapy or psychopharm or a combination of the both. If you go to a pain clinic and you look at people who have pain, but they have no adverse childhood events, their pain is, the level of pain is much lower than the person who has ACEs. And the reason is because the developmental effect of the brain at that time makes you perceive pain as worse, you feel pain as worse, and when you use opioids, because of the effect on the amygdala, you're not as opioid receptive to what is being given to you, and they're more likely to get addicted. That's just one little tiny piece, you know. So from my perspective, everybody in a pain clinic should be teaching these people CBT, because it is their anticipation, their fear of the pain because of what happened developmentally to the amygdala early in life that causes their perception of pain, their anticipatory fear of it, and their inability to respond to opioids. That makes this a problem. So you got to be broader in your specialty, I guess is what I'm saying. No matter what specialty you have now, you have to be broader. You can't really do as much for patients if you don't know more. And, you know, I always feel like you also need to know when the abuse occurred, because there were 2 wonderful studies looking at psychopharm and psychotherapy and then a combination. And people who have ACEs or chronic childhood abuse don't respond to traditional medicines. And the reason for that is epigenetics, because certain traumas at certain times are going to demethylate or remethylate genes that are then going to be expressed. So for instance, with the FKBP5 gene, children who are chronically abused, what happens with that gene, it demethylates and it gets expressed. And what happens is you then have less glucocorticoid receptors on the HPA axis. So when you get stressed out, you can never have negative feedback. You don't have enough of the glucocorticoid receptors so that cortisol can bind to it and say, shut down, you don't need to be activated right now, or they're less sensitive. And those people do not respond to normal psychotherapy. So, you know, I look at everything in terms of epigenetics, the effect on the brain, you know, what's the mediators, what's continuing this neuroinflammation or inflammation throughout the body to continue. And in American society, it's lifestyle.
So you would call yourself then a functional psychiatrist?
I'm a functional medicine doc.
Because there are a lot of people, I gave a talk this morning, and you know, a lot of the people are OBGYNs, internists, anesthesiologists, all these specialties, and what brings them together is the desire to look at the whole patient and to understand how to keep that patient healthy.
Right.
So tell me how you see yourself in that scenario.
Okay, so yes, I trained in psychiatry. And so people are going to look for a psychiatrist if they think they're depressed or whatever. But, so they'll come to me. The uniqueness is that I'm not gonna throw, I haven't used an SSRI in 6 years.
Bravo
and
to
so, but because I'm gonna look at why you got there.
Of course.
I think traditional medicine's been about symptoms.
Diseases,
and then,
labels.
Right. And what happens is that people see a symptom and they give a medicine and they try to stabilize. But they're never finding out why. They're not finding out, how do we get there? What is it? I want to get you to the pre-disease state, not keep you in the disease state and stabilize. I want to go beyond that.
You know, there's just such an overabundance of medication that is given by psychiatrists to young people, to 8-year-olds. You know, we have an 8-year-old in the practice who's taking Adderall and Vyvanse, which I find...
Adderall and Vyvanse together?
Yes. They're doing it, yeah, so, right.
Well, but,
so
but you also have to know
why.
There are some genes, though. You have a comp gene, and if you have VAL-VAL, you're breaking down dopamine consistently all the time.
Right.
And so if you know, a child's quality of life and self-esteem is extremely important to me. And let's say it's towards the end of the year, and they're having a miserable year, and I find out they're breaking down dopamine all the time. I may use a stimulant in them so they have a successful end of the year.
Right.
You know, you use medications to look at the whole person. You've got to be able to emotionally connect with your patients.
Right.
You've got to say, you don't want to get so, like psychiatrists say, I'm only going to use meds. You also don't want to be the functional medicine doc to say, I never use meds, they're bad. You got to know when to use them.
Well, that's what we do here. We're the bridge.
Right.
We believe in the bridge.
Exactly.
But having said that, what about the patients who get put on on medication, just, let's say, to get them to baseline, and then 20 years later, they're still taking it?
Well,
and because one psychiatrist has seen them, and then they've seen 20 others, and they just stayed there with the medication. What do you tell those psychiatrists?
Well, again, you're asking me questions that really, as you're asking, I'm thinking of all kinds of different things. You also have to know that stimulants improve auditory working memory. And so if I've had a kid who's had chronic ear infections and they now have a severe auditory working memory problem, then that kid may choose, and you do have to have that relationship with your patient.
Right.
We've done everything else we can. We've taught them compensatory mechanisms. They can't change the way the teacher teaches.
Right.
They can't do that.
Right.
And so they may choose, I'm going to do this until my frontal lobes do mature at age 24. And at age 24, I'll have better ability to inhibit a lot of this stuff. I'll continue using what I'm using. But there are cases where people and the patients say, I don't have traditional ADHD, but doc, I can't learn by hearing. It's not, you know, I had a case where I had a girl who had a verbal and performance IQ above 140.
Wow.
And auditory working memory and processing speed was in the 90s.
Interesting. Yeah.
Okay, so what, am I going to say medicine's bad for her? No, I'm going to have a personal relationship with her. I'm going to educate her. I'm going to teach her everything she needs to do, if she's willing, you know, to overcompensate. But if she says to me, I know I'm smart, and I'm doing everything you're telling me, Dr. Simkin. I'm going home and I'm reading a paragraph and I'm asking myself if I can explain to somebody. No, I can't. So that's an auditory skill. So I read it until I can explain it. And then once I can explain it, I write it down on a piece of paper so I can see it. So when I go to take my test, I just close my eyes and see my notebook. But when I have a processing speed problem, Dr. Simkin, and this teacher's talking at 90 miles an hour and she doesn't use any visual skills, I want my medicine. And I'll just say, keep doing what you're doing. I'm not going to tell you it's wrong. But, you know, that person's not misusing a drug. That person's doing it for a reason because she can't change the way she's being taught. But think about this. If you've got a processing speed problem, you also have to tell that parent to go to every teacher every year, take a little 3x5 picture of the person, write on the back the period that they're in, write the problem, auditory processing, working memory, processing speed. Why? Yeah. So that when the kid does this, would you repeat that, please? They won't say, you should have listened the first time.
Right.
You know, so I think we have to bridge. We have to look at what's going on. I'm not going to say everything is bad about medication, but I also think that it has to be a personal relationship, and I do think that's what we've lost. The art of medicine is your emotional connection to the people you treat.
And that's what we say at A4M, and we've been saying it. I've been saying that for 30 years.
Yes.
And I think that you are a perfect example of what psychiatry should really be like, and how you should look at the patient and look at the whole patient, understand the person, care about them, understand what's the issue that's caused them to be who they are, and then correct that.
Yes.
So, Dr. Simkin, thank you so much for joining us today.
Thank you.
Because Dr. Simkin is really the kind of psychiatrist that A4M really embraces, because we're here to bridge the gap between the conventional world, the integrative world, to look at the patient as a whole, to know the patient, because then we'll be able to provide the care that the patient actually needs.